this letter we're going to have a grand CPC on the 16th March about obesity. It's a worldwide problem. I'm going to focus on the medical side of obesity, but we're going to target obesity, including surgeons, psychiatrists, and dietitians. Hope to see you all there on 16th March.
So I would like to welcome you to this upcoming CPC, which is going to be devoted to the various aspects of treating obesity, and I'm sure that you will all enjoy it.
My name is Dr. Samra Fakar, Resident Surgeon, Surgery Department, Khyber Teaching Hospital. I, on behalf of the Department of Surgery, Khyber Teaching Hospital and Khyber Medical College, welcome you all to the second multidisciplinary CPC on the theme of obesity today. Before we formally begin the program, I'd like to invite Tayyar from final year to recite a few verses from the Holy Quran, and we'll begin afterwards.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. إن بطش ربك لشديد إنه هو يبدئ ويعيد وهو الغفور الودود ذو العرش المجيد فعال لما يريد. هل أتاك حديث الجنود هل أتاك حديث الجنود فرعون وثمود بل الذين كفروا في تكذيب والله من ورائهم محيط بل هو قرآن مجيد في لوح محفوظ بل الذين كفروا في تكذيب والله من ورائهم محيط بل هو قرآن مجيد في لوح محفوظ صدق الله العظيم.
Jazakallah. We're already a house full. They say coming together is a beginning, keeping together is progress, working together is success. As envisioned by our worthy Dean, Professor Dr. Mahmood Aurangzeb, the multidisciplinary CPC has been brought to the alma mater yet again. And for the students, I'd like to particularly mention the vision is to include you guys at the undergraduate level to expose to the clinical and pathological aspects of different subjects, which is why today the theme of obesity will be covered by a whole lot of specialities, and it is a golden opportunity for you to hear from the best consultants in their fields speak on the topic to you. This is a crowd of one of the finest consultants. I'm very grateful to all the presenters for working on their presentations and timely submissions to us. Given the vastness of today's theme for the conference, we have in line a number of presentations from different specialities. They'll come together and share their knowledge on the subject. Before that, and for all more lined up, first I'd like to invite the lady who is behind this all. I'd like to invite the worthy chairperson, Department of Surgery, Professor Dr. Mamunir. A round of applause for ma'am for her opening address.
Thank you, Samra. Just I begin with a word of appreciation for Dr. Tayyab, who did the lecture today. A lot of talent amongst our students, and I'm sure this will be brought out by our worthy dean. Bismillahirrahmanirrahim. Professor Mahmood Aurangzeb, Dean, Khyber Medical College. Ladies and gentlemen, Assalamu alaikum. It is an honor for the Department of Surgery to host the second event of the recently revived and, I must say, revamped CPC at Khyber Medical College. The first event was hosted by the Department of Medicine on thrombocytopenia, and that generated a lot of interest and enthusiasm. And I'm sure today's topic, that is a burning topic, obesity, will also generate a lot of enthusiasm and interest. Many years ago, or should I say a few years ago, Dr. Ruxana is my class fellow and Dr. Mushtaq as well, and you would remember when we were in the opposite hall being taught by community medicine, one of our professors, Professor Zahir Shah, he said that malnutrition is not just being undernourished, it also means being overnourished, which leads to obesity. So being undernourished or overnourished both means malnutrition. I don't know if it holds true today. The Department of Community Medicine and Preventive Medicine is busy today, but we have speakers from a wide array of specialities, and we are very thankful to them for joining us. And this also shows the importance of a multidisciplinary approach in tackling various problems, and that is the need of today. Professor Mohammed Zareen, he's the department's focal person for academics, and I'm very thankful to him and his team, namely Dr. Marian Irjan and Dr. Samra and many more others who worked tirelessly to arrange this event. As I was walking to my office this morning, I was thinking to myself, obesity, maybe it would, the talks would revolve around surgery, but I was pleasantly surprised that there's a lot more to that, a lot to learn actually. And Professor Dr. Imran, the chairman of Psychiatry, he we discussed this morning. He asked me whether it was all right to bring over a patient with anorexia nervosa if she consents to it. And I said, but anorexia nervosa is not the theme, it's obesity. And he very aptly explained to me how important the relationship of anorexia nervosa is with obesity. So I hope this continues. I would also like to appreciate the efforts of Dr. Iqbal Haider. It was full marks last time. I don't know if he's here today, but it will surely continue to be full marks in future as well. I hope this continues. Finally, Professor Mahmood Aurangzeb, Dean Khyber Medical College, his efforts in taking Khyber Medical College to new heights, his efforts are showing and will continue to show. I think I will be overshooting my 2 minutes. I hope Samara doesn't ring the bell. And I won't keep you and from the speakers of today. Thank you very much.
Thank you so much, ma'am. As for the bell, it's not that scary. The idea is to keep the presentations brief and pretty to the point. Thank you so much, ma'am, for your time and your valuable words. It is an honor for me to be addressing an august gathering like the one today. I'm in the company of the finest faculty, very pleased to see the bright students here with us as well. And I'll keep repeating for the students, if you maintain the decorum, this will go smoothly, so kindly avoid a lot of movement and sure we're not going to. I'd like to encourage the audience to keep the seniors session interactive by asking questions towards the end. Ask for the mic quietly and it will come to you. You can ask for the mic. A shout out for the CR and GR final year. They've been a huge help. They're here with us. Also, the video that you just saw being played in the background, I'd like to have a special mention for Danish Ali Khan of final year. He helped compile this film. Ladies and gentlemen, as we all know, the second multidisciplinary CPC is being hosted by the Department of Surgery in alliance with all the other departments. So without further ado, I'd like to invite Dr. Ghazala of Surgery Khyber Teaching Hospital to come on the stage for her case presentation and formally begin the obesity lead.
Obesity has become an epidemic. Nearly 2/3 of American adults are overweight or obese. 55% do not get enough physical activity. 26% are completely inactive. Only 25% eat the recommended amounts of fruits and vegetables. Over the last 20 years, here's what has happened with our food consumption. Hamburgers are 23% larger. Soft drinks have increased in size by 52%. Snack portions have grown by 60%. Standard dinner plate sizes have increased by 2 inches. As food portions and plates have grown, so have our waistlines. The yearly medical costs of obesity are estimated at over $147 billion. This figure has ballooned by more than 80% over a 5-year period. 75% of healthcare costs stem from preventable chronic conditions. Overweight and obese men have significantly more medical expenses per year than those in a healthy one. This figure is even larger for women. 3% of the U.S. workforce is morbidly obese, but accounts for 21% of obesity costs.
Assalamualaikum, I'm Dr. Ghazala Preeti, a postgraduate resident at Surgical Khyber. I'll be presenting my case today. My patient is a 38 years old male who is lawyer by profession. He has been hyperglycemic for the last 1 year. He was smoker and was normotensive. He presented to our bariatric surgical clinic. He was diagnosed with type 2 diabetes a year ago, but did not show any improvement in his diabetes and weight despite trying oral as well as injectable treatments. His weight has been increasing steadily over the last year. He was assessed according to our criteria and was found to be eligible for bariatric surgery. As per history, he has not been subjected to any major surgery. He had a lipoma removed previously. On his systemic review, no signs and symptoms were found that suggested any disease in any other system, including his endocrine. Thus, no other factor that could lead him gaining weight could be found. There was a strong family history of morbid obesity in his first-degree relatives, and our patient has no known allergies. He was evaluated in the pre-operative bariatric clinic. He had a BMI of 52.2 kg per meter square, being classified as class 3 obesity. He had a weight of 160 kg. His standard measurements were taken and his baseline investigations turned out to be normal. His blood sugar level was monitored and showed a fasting blood glucose level of 240 mg per deciliter and above consistently. He had his HB monitored, that was 14 at the time of presentation. His blood pressure though remains within the normal ranges. He was referred back to his endocrinologist for optimizing his blood glucose levels, and after a period of a week and so his HbA1c was improved to 11 by adjustment of insulin dosage. He underwent evaluation where a pre-formed checklist and consultation with cardiology, pulmonology, anesthesia, and endocrinology department. He was planned for bariatric surgery after informed consent for one anastomostic gastric bypass. Preoperatively, he was given prophylactic dose of low molecular weight heparin, and standard 5-port 1 anastomosis gastric bypass surgery was done. His recovery was uneventful, was shifted to surgical ICU for post-operative surgical care for 24 hours. He was started on the post-operative diet plan on the second post-operative day and finally discharged on the third day. This was the pre-operative checklist that was followed during his admission. The basic focus was on the fasting blood glucose level, the fasting lipid profile, his nutritional screening, then his cardiopulmonary DVT as well as sleep apnea profile. He had underwent a GI evaluation and endocrine workup. He was evaluated by a nutrition who was registered dietitian, and a psychosocial behavior evaluation was done. Informed consent, and after relevant information regarding the financial aspect of the surgery, he consented and was operated. He came to clinic for follow-up after 1 month, which showed a reduction in weight of 20 kg. That is about 25% of the excess body weight he lost. His HbA1c was down to 9.2, and that also helped him in the reduction of insulin dosage. Initially, he was on Himalayan 70-30. He used to take 30 units in the morning and 20 units in the evening. The dose was reduced to 12 units in the evening, followed, and currently he is not taking any insulin or oral antidiabetics, with his blood glucose level within the normal ranges. That resulted in total remission of his diabetes. This is the graphical representation of his fasting blood glucose level that was monitored daily. It was 140 and above in the immediate post-operative period, with a decline to 108 within the last few days. His HbA1c declined from 14 to 10 and 9.2. This is the pre-operative and post-operative picture of the patient we operated on. Thank you.
Thank you so much. This was Dr. Khazana presenting the case. We have numerous of these cases coming into the surgery department, Khyber Teaching Hospital. And for the students, I hope you all are taking interest because it must be something new for you. To take it further and speak to you in detail about bariatric surgery and a thorough review, may I please have on stage Dr. Asad Maroof, Assistant Professor, Surgery Department, KTH. A round of applause for our faculty, please.
Bismillahirrahmanirrahim. Okay, bariatric surgery, a thorough review. Well, it's very difficult to give a thorough review in just 10 to 12 minutes, but I will try to highlight the merits and demerits of bariatric surgery in terms of outcome like weight loss and metabolic improvement after surgery. So, the obesity is defined on the basis of BMI, body mass index, that is weight in kg divided by height in meter square, and you can see that the normal range is 18 to 25, 25 to 30 is obese, and beyond that is overweight, and beyond that is obese, further classified into class 1, 2 and 3 on the basis of BMI 30 to 35, 35 to 40 and beyond 40. Now, if a person is obese or morbidly obese, what are the treatment options that are available? There are three broad categories that are available. One is the lifestyle modification, pharmacotherapy and surgery. The pharmacotherapy means the medical management. My colleagues from other specialties will concentrate on the lifestyle modification and medical management. I will concentrate on the surgical management of obesity. Okay, the timeline of surgical procedures. The surgical procedures for obesity are not old enough. They were introduced in the last century. In earlier 1950, they started with a gastric ileopholic and ileoilean bypass, where the concept was to decrease the absorption of nutrients. Then came the Mason, who is taken as the father of bariatric surgery. He first introduced a gastric bypass, followed some years later by a vertical banded gastroplasty, and then the Griffin introduced the Roux-en-Y Biliopancreatic diversion, gastric bypass, which was in fashion during 1990s, and later on the laparoscopic approach was introduced. But I think the main turning point was the use of laparoscopic staplers and the energy devices like harmonic scalpel and Thunderbeat and Ligashore that revolutionized the use of surgery and treatment of bariatric patients. Okay. Patient selection criteria for bariatric surgery. Actually, they say that those who can benefit from bariatric surgery, only 1% they opt for bariatric surgery because of certain barriers we will discuss later on. But there are three main categories. One is the eligibility criteria, that is straight away more than BMI 40, BMI more than 40 is the straight away indication for bariatric surgery, with a component of use of medical and lifestyle modifications. And there is another component, that is commitment. If the patient is not aware of the post-operative course and he is not committed for that post-operative workup, he should not opt for bariatric surgery. Okay. Contraindications. You can see the contraindications for surgery. My colleague from anesthesia, they will discuss that. Reversible endocrine disorders, where the obesity can be reversed without surgery. Current drugs are alcohol abuse. If a patient is using alcohol or is smoking, he should stop smoking at least 6 weeks prior to the surgery. Uncontrolled psychiatric illness and lack of comprehension of risk and benefit is again a relative contraindication for bariatric surgery. Okay, the checklist, Dr. Ghazala has already discussed the detailed checklist. The points are that you will have to take a detailed history to identify the BMI, to look for the commitment on the part of patient for the post-operative workup and follow-up, and the routine labs, nutritional and CVS assessment, gastrointestinal and endocrine evaluation, and pre-op psychosocial and behavioral evaluation of the patient, whether he will be able to continue or not. Now, the obesity surgery or bariatric surgery is not a one-man show. You need a well-coordinated and well-trained team, and that team includes, but it's not limited to, bariatric surgeon, dietitian, anesthetist, exercise therapist, specialist nurse, bariatric physicians, radiologists, and there is a role of patient support groups that can enhance the patient education and awareness regarding bariatric surgery. Okay. The human resource is not the only requirement. We need a lot of infrastructure to operate upon bariatric patients, and that includes purpose-built, extra-wide doorways in the operating room, scales that can measure morbidly obese patients, and a proper purpose-built bariatric table that is used to operate upon the patients with adjustable portions for making it for putting the patient in a tantalum bulk position. Okay, what are the common procedures that can be offered to a obese person? There are 4 commonly performed procedures with a variety of other procedures and modifications. First, the historical Roux-en-Y gastric bypass, where a 30 cc gastric pouch is made in the proximal area, and that is attached to the mid-gut, and lower down there is an anteroenterostomy. This alimentary limb is usually 100 to 150 centimeter, while this biliopancreatic limb is usually 30 to 60 centimeters. Actually, there are 2 types of bariatric procedures. One is restrictive, that will restrict the diet, and the others are malabsorptive. Now, this Roux-en-Y gastric bypass is a combination of restrictive as well as malabsorptive procedures. But as there are a lot of anastomosis, so it tends to create more post-operative complications like internal herniation.
Access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdominal cavity using a laproscope or video camera. A small stomach pouch is created using a stapling device. The small intestine is separated into 2 sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. The upper portion of the small intestine is reconnected to the lower part of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested.
Now, another procedure, the Roux-en-Y gastric bypass was performed more frequently in the last decade of last century, but now the number of Roux-en-Y gastric bypass is going down, while the sleeve gastrectomy is picking up because it is relatively safer and easier to perform laparoscopically. Now, in this case, a tube in the lesser curvature is made over a 35 size French bougie, and the rest of the excess stomach on the greater curvature is removed. It cannot be reversed because the stomach is already removed.
During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 and 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. By altering the anatomy of the gastrointestinal tract, sleeve gastrectomy changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals. The bile and pancreatic fluid from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel.
Though this sleeve gastrectomy was actually introduced initially with duodenal switch, and it was a type of restrictive procedure, but somehow it has some malabsorptive effect as well. The next is one anastomosis gastric bypass, which is gaining popularity in the contemporary bariatric surgeons. The beauty of this procedure is that it involves only single anastomosis, and it has both restrictive and malabsorptive components, and it is less prone for complications. But the data is cooling up. The safety and efficacy is still not fully developed.
Surgical stapler is used to create a pouch at the top of the stomach. The small pouch, about the size of a small banana, limits the amount of food you can eat before feeling full. Next, a 150 centimeter to 200 centimeter segment of small bowel to be bypassed is measured off. A loop is brought up and connected to the newly created pouch through a sutured or stapled connection called an anastomosis. Bile and digestive fluids from the liver and pancreas allow food to be digested completely.
The only theoretical complication is that bile reflux and chances of Bariatric esophagitis and later on complications. But luckily, in our experience, the incidence is not that much. Another option is laparoscopic adjustable gastric banding, where a band is put in around the upper stomach, making a pouch, and the band is gone through the lesser omentum. Now this is that's adjustable balloon and a reservoir accessible in the anterior abdominal wall. So after putting it laparoscopically, later on there are serial visits to adjust the size of the pouch and to control the nausea and vomiting associated postoperatively with this procedure. Biliopancrotic diversion. Again, you can see there is an alimentary limb and there is a biliopancrotic limb. Here, the alimentary limb and the common limb is very short, but irrespective of the length of the biliopancrotic limb. So these procedures will lead to maximum malabsorption and their inherent complications. And they claim that these procedures can bring an outcome of 60 to 80% of excess weight loss, but at the cost of complications. Duodenal switch, again, you can see the stomach tube is, initially it was a combination of sleeve gastrectomy and duodenal switch. Now there's a sleeve gastrectomy with an intact pylorus, and this pylorus is attached with a small distal ileum. And again, you can see that the alimentary and the common limb are very short and the biliopancreatic limb is very long. So again, it will lead to a lot of malabsorption and micronutrient deficiencies in the post-operative period. Now, those who are unable to undergo surgery, there are options: sleeve gastropexy. There is a balloon, inflatable balloon, either a single balloon or either a set of 2 or 3 balloons, because if the single is deflated, it will pass on. So to counter that, some systems they provide 3 or 2 balloons set. Again, it is a restrictive procedure. And the last, single anastomosis duodenal ileal bypass, that can be done after a sleeve gastrectomy if there is a remission, if there is a recurrence of obesity. Again, a very extensive procedure with a lot of malabsorption later on. Now you can see that if you look at the 4 common procedures, the LAGB, gastric banding and sleeve gastrectomy, they are relatively safer, but they will give an outcome of 20 to 25% maximum weight loss. While doing via gastric bypass and biliopancreatic diversion and duodenal switch, they are more extensive and they will need a lot of follow-up after surgery. But they claim that they can lead to 60 to 80% of excess weight loss. Now, the metabolic effect of bariatric surgery. Almost 70% of diabetes, dyslipidemia, and hypertension, they will remit. And mostly the patient on diabetic medicine, they can stop the anti-hyperglycemics, their insulin even. And the same happened in the case which was presented earlier. Now, complications of bariatric surgery: anastomotic leak, which is more where there are more anastomosis, and there is a specific point angle of his in the sleeve gastrectomy where it can leak. There can be bleed. There can be the micronutrient deficiencies. Now, we have done the bariatric surgery. We have an outcome of 60% weight loss, but the body remains the same. So for that purpose, the plastic surgeon can come in and offer a standard circumferential abdominoplasty or upper or lower body lift, or a combination of procedures that can be done in a single setting in 8 hours. Thank you very much.
Thank you, Dr. Asif. This is an announcement for all the trainees in the house. A form of attendance will come to you. Students के लिए नहीं है, only the trainees, postgraduate faculty and trainees will fill the attendance form. Write your PMDC number, your correct email address. This is important for the accreditation. Also for the students, sit tight, there's a student quiz at the end of this, and the questions might be appearing from one of these presentations. तो इसको जरा गौर से सुनना है. As spoken by Dr. Ghazala.
मेरा नाम सुफियान मलिक है। प्रोफेशनली मैं एक वकील हूँ, पेशावर हाई कोर्ट में प्रैक्टिस करता हूँ। वेट लॉस सर्जरी के बारे में थोड़ा बहुत एक्सपीरियंस जो अभी तक हुआ है, क्योंकि मेरा 1 मंथ हुआ है, तो वो मैं शेयर करना चाहूँगा। 1 साल पहले मैं डॉक्टर जरीन साहब के पास आया था। इसी सिलसिले में सारे मेरे टेस्ट वगैरह हो चुके थे, लेकिन एट द एंड जब सुबह मेरी सर्जरी, तो रात को मैं निकल गया था, क्योंकि सब दोस्त कह रहे थे कि यार ये नहीं करना, इसमें काफ़ी कॉम्प्लिकेशन है, काफ़ी मसाइल है। तो 1 साल पहले मैं भाग गया था यहाँ से। फिर अभी 7 फरवरी को मेरी सर्जरी हुई है, 7 फरवरी 2022 को। वो भी डॉक्टर जरीन साहब ने किया। दोबारा मैं आया हूँ, टेस्ट वगैरह किए। अच्छा, 1 साल पहले जो मेरी HbA1c थी वो काफ़ी कंट्रोल में थी, 1 साल बाद ज़्यादा हो चुकी थी। तो फिर मेरी HbA1c जब एट द टाइम ऑफ सर्जरी 14 थी, फिर डॉक्टर साहब ने सजेस्ट किया कि इसको थोड़ा कंट्रोल करें। 1 हफ्ते की डाइट दी गई मुझे, उसमें वो मैंने इतना कंट्रोल तो नहीं हुआ, लेकिन 12.8 13 समथिंग आ गई थी। उसके बाद सर्जरी मेरी हुई है जनाब 7 फरवरी को, और अभी तक 1 महीना कुछ ऊपर हो चुके हैं। 22 kg मैंने वेट लॉस किया है इसमें। और जो मेरी HbA1c थी वो भी अभी मैंने रिसेंटली 2 दिन पहले चेक किया, तो वो 9.2 14 से 9.2 पे आ चुकी है। अच्छा, जो फास्टिंग पे मेरा ब्लड शुगर था वो भी 110 115 तक आ गया है। इंसुलिन मैं तकरीबन 20 यूनिट शाम को लगाता था, इसी तरह 30 सुबह को थे। 50 प्लस यूनिट्स मुझे लगते थे, वो अभी कंट्रोल के खत्म ही हो चुकी है। क्योंकि मेरे जो डॉक्टर साहब हैं, डॉक्टर खालिद उस्मान, जो ये डायबिटिक वाले हैं, उन्होंने वो इंसुलिन वगैरह मेरी खत्म हो चुकी है। अभी नॉर्मली मेरा 1 हफ्ता हो गया, मैं 110 115 मेरी फास्टिंग पे आती है। मैं तो यही सजेस्ट करूंगा, सब जो मेरी तरह के मोटे लोग हैं, एटलीस्ट, एक तो वेट कम होता है, दूसरा जो मेन इसमें है ये शुगर कंट्रोल होती है। वो शुगर जो है तो बीमारियों की जड़ है, वो इससे खत्म होती है। ब्लड प्रेशर का जो इशू था वो, अच्छा, मेरे और काफी मसाइल थे, चलने फिरने में मैं काफी तंग होता था, वो भी मेरे काफी हद तक अल्हम्दुलिल्लाह सेट हो गया। एस्थमा का प्रॉब्लम था, वो भी मेरे इसके साथ काफी हद तक कंट्रोल हो गया। मैं 2 पफ सुबह लेता था, सर्मी कार्ड के 2 शाम को, अभी सिर्फ 2 मॉर्निंग में लेता हूँ, और वो भी डॉक्टर साहब कहने के आहिस्ता आहिस्ता आप इंप्रूव करेंगे, वो भी खत्म हो जाएगा। तो मैं तो हर एक उस बंदे को रिकमेंड करूंगा कि जिसका वेट ज्यादा है या जिसको शुगर का प्रॉब्लम है, कि वो काइंडली एटलीस्ट बैरियाट्रिक सर्जरी की तरफ आए। थैंक यू।
As you heard from the patient, his entire life quality changed. It was not just about weight loss. He was having issues with his diabetic control. He has problem with his asthma. Other life quality has improved immensely. This is the idea, the message that we're trying to send across is that obesity is a disease. It should be considered as one. It should be prevented. To speak more on this, we have a whole list of presentations coming up. Let's have on stage Dr. Hamza Ali Khan from the Department of Medicine. He's going to speak to us about obesity from a medical perspective. A round of applause for sir. लेक्चर थिएटर का स्टाफ जो है, जब वीडियो प्रेजेंट हो रही हो तो लाइट्स अप कर दिया करें, इधर रिकॉर्डिंग चल रही है, पिक्चर्स भी दे रही, ठीक है?
Bismillahirrahmanirrahim. Thank you very much for giving me a chance to speak on this prestigious forum. I'm definitely going to speak about the medical perspective of the obesity, but I would just like to know Does anybody has any idea that how many people are obese worldwide in Pakistan? Any idea? Too many. Well, we do not have actually WHO data recently, but in 2016 there were 1.9 billion people, they were overweight, and out of this 650 million in the obese criteria. From Pakistan, luckily we have some recent data into 2022. We have actually in adult 8.6% obesity. So and this is really a problem. 8.6%. So what do we want? What do we want to learn from this lecture as a final year students, because most of us are final year students on the back and some seniors in the front as well. So what is obesity, and what it can cause? If somebody gets obese, what complication can he get? Is there any medical treatment available whatsoever for the obesity? And definitely we need to have various non-surgical techniques to avoid or reduce obesity. WHO is a body mass index. What we would like you to have actually BMI between 25 and 18.5 and 24.29, which is the normal BMI. Anything beyond that comes in overweight up till 29.9, and definitely more than 30 is obese. Now let me tell you, these are actually the BMI calculator for Caucasian. For Asians, we have a lower BMI, just cut 2 from the upper. I think this is the slide that why we are here. It's just to show you the importance of the obesity. Now, this is a meta-analysis which was published in Lancet of 900,000 people, showing that those who have a higher BMI, actually they have a higher rate of mortality. Now, if you see on the higher BMI side, both male and female, the overall mortality increases with increasing the BMI. So that's why we worry about obese people. This is another study both for male and female health professional studies, and it shows that even modest increase in the weight by 10 to 15 kg, these were the guys who were followed for 10 to 15 years, would increase the chances of you having a diabetes, cholelithiasis, hypertension, and cardiovascular disease. For medical students, obesity can affect any part of your body from head to toe, with increased chances of stroke, with increased chances of cardiovascular event, dyslipidemia, and even the blood dyscrasia, solid organ tumors, difficult to treat the infections, particularly soft tissues infection, post-operative care, NASH, alcoholic hepatitis, cirrhosis, pancreatitis, particularly when the chest physicians are sitting in here, sleep apnea, Pickwickian, increased residual volume, decreased muscle drive, even asthma is more common in obese people than non-obese. So what is the goal of therapy treating an obese person? We want, first of all, to reverse, treat, or at least prevent the complication of obesity that a person might have. When I was a student, I was told that if you take a low-calorie diet, you can reduce weight. Now, what is a low-calorie diet for an adult? Simple, it should be less than 1,000 kilocalories per day. Now, the diet only doesn't work. You have actually to have an exercise to spend the extra energy and burn out. Along with it, behavior modification. Unfortunately, we are less and less stressing on the behavior modifications, and I'm happy that my psychiatric colleague has been involved here. I'm not sure about the practice of Professor Zareen, and I'm sure he's doing I have been a part of the bariatric surgeons. We definitely used to refer patients to a psychiatrist before going for a bariatric surgery. So, who are the candidates who can get a medical treatment? Definitely we want to treat people who are above the range. Now, definitely above the BMI of 30, obese people can be a potential candidate for drug treatment, but those with a BMI of 27 to 29.9, if they have any obesity-related complications that we just went quickly through. Loads of drugs came into the market and they went off gradually. None of them had actually sustained impact, and the reason being that they had too many side effects. You can see the number of years written with it and they went off. We have some FDA approved drug at the moment, and they are, the one that we all know is Orlistat. It works well for some people, but definitely it has the side effects of giving gastric symptoms with the fat malabsorption. You need to use it in its full dose to have the full effect. Now, let me tell you about the drugs. Any drug that you select to use in your patient, you need to give the initial trial of 3 months. The recommendation is if somebody doesn't have a 5% weight loss, you discontinue the drug. The drug is not effective in that particular person. It's slightly different for GLP-1 analogs. GLP-1 analogs have been, initially they were introduced as incretin mimetic. They were used for diabetes, but later on we found out that they are good in weight loss as well. So you can carry them on if the diabetes is well controlled for 6 months, if they have a 3% weight loss, or if the diabetes is under control. So it's a different criteria, but any drug, weight loss drug, if not 5% of the original weight loss at 3 months, you just discontinue. So there are certain other drugs that are available as well, which we know is phentermine and topiramate combinations. Definitely they have their own side effects of dryness, constipations, and so on. We have naltrexone available, bupropion combinations. As I said, they have their side effect as well, with the tachycardia, dizziness, diarrhea, and they may induce suicidal ideation. We did speak about the incretin mimetic, liraglutide and semaglutide. What do they do is, their main mechanism of action is that actually they make you sick. When they make you sick, you eat less, particularly the first couple of weeks. You need to be careful. They can sometimes induce pancreatitis. So if they complain of the severe tummy pain and come to you, you need to make sure that they haven't got the pancreatitis. Luckily, it's not very common, and the literature would say that anyhow type 2 diabetes, which usually it is prescribed, would get a pancreatitis slightly higher than the usual population, and the liraglutide and all these exenatide would increase by 1% more. There are certain drugs that are used in a pediatric populations, injectable, and they are usually used in those syndromes where either you have leptin receptor antagonist disease or pro-apomyelineurotic deficiency. Some very rare drugs that you can use it, and they are actually short-term drugs where you think that the treatment that you are giving might put on weight. So they're not used more than 3 months. So, coming to the more interesting bit of it, that what else we can use for the patient, non-bariatric hydrogens. These are actually inert substances. They just swell up in the stomach, and anything that swell up in the stomach or take the place in there would induce satiety. So they've been used a couple of times a day before the meal, and when they fill up your stomach, you eat less and you lose weight. Definitely you have to observe the diet. You don't fill up the rest of the stomach with the juices. So it is indicated for any BMI between 25 to 40. Laproscopic adjustable bands you can use to reduce the size of the stomach, and they can be indicated for any body with a BMI more than 40, or if somebody has weight-related comorbidities more than 35. Vagal stimulation. Now we know that vagus nerve is involved in emptying of the stomach. So if you have a mechanism of stimulating or blocking of that vagus nerves, that would induce satiety with reduced eating and weight loss. It's indicated for people with a BMI of 40 to 45 and a lower BMI of 35 if they have weight-related comorbidities. Gastric balloons. My surgical colleague spoke about the gastric balloons. Gastric balloons can be used as a primary or as an adjunct to your treatment. Particularly, Dr. Zareen might actually comment on it in a people with a morbidly obese, those who have BMI of 50 or above. A surgeon would want to have actually a bit reduction in the amount of the fat. They put a gastric balloon. They put the gastric balloon to reduce the size of the stomach before they can do the definitive surgery. Gastric aspiration is something like gastrectomy tube. The person eats, they aspirate whatever they have eaten. Now, surgical colleagues did discuss about the bariatric surgery. It is indicated for anyone about the BMI of more than 40, but definitely from 35 onwards if they have a weight-related serious comorbidities. Obesity is on the rise with the sedentary life that we have, and it is going to increase, and it's going to be the problems. It's our problem. It's definitely junior problems as well. We need to realize this. We need to catch it. We need to have a multidisciplinary approach. I'm very happy that psychiatrist is here as well today, and we need to have all the modalities utilized. Do not rely too much on the drugs. Drugs at most would cause you 5% of the weight loss. It's usually the behavior that needs to be changed. Thank you.
Thank you so much, Dr. Hamza. I'd like to particularly thank Dr. Hamza and Dr. Iqbal Haider for guiding us along the way, since they did the first one. Once more for the students, the attendance sheet that is rotating is not for you. It's not for you, it's for the postgraduate trainees, okay? So pass it on to the next postgraduate guy sitting next to you. As Dr. Hamza mentioned in his presentation, a big role of behavior modifications and psychiatric consultation is there in the obesity and weight gain as well as weight loss processes. I'd like to invite on stage Dr. Imran Khan from the Psychiatric Department of Khyber Teaching Hospital to speak on the psychiatric aspects of obesity. A round of applause for Dr. Imran.
Thank you very much for inviting me to this forum to talk about the psychiatric aspects of obesity. Can you hear me, please? Right. So, why should a psychiatrist be invited to a forum where we are talking about obesity? Something has already been discussed by our colleague. I'll be brief because we cannot discuss all the details. This is our medical college where we are currently studying. Proud of it. The topic for today is the psychiatric aspects of obesity. We will just go through these and we will give you a few messages only. The psychosocial aspects of obesity. If you look at anyone who is having obesity, he or she may not be she will not be worried of the physical complications. Rather, the first thing is, how do I look? If you have a couple of, for example, infertility, they may not be worried about not having children, but they are more worried about telling everyone that they don't have any children. Similarly, obesity if somebody is having morbid obesity. यहाँ पर ये जो स्टूडेंट्स आपको बताऊँ, obesity is defined जिस तरह आपको बता दिया already 25 kg per square meter से शुरू होके 40 से ज़्यादा, 25 is just overweight. We are not talking about overweight. We are talking about morbid obesity having more than 40 BMI. So, eating disorders, anorexia nervosa, as the name indicates, anorexia nervosa, the patient will be preoccupied. मैं पहले आपको चंद slides दिखा दूँ. These are different things you have already studied and they have already told you. We will not go into this detail. Stigma, discrimination, lesser chances of getting into the jobs, lesser chances of getting even married. So, cultural differences को आप लोग कभी भी don't forget the cultural the factors. Like Professor Zafar Hayat would tell us that the lady is actually having Cushing-Guy's syndrome, but the mother is looking for a spina bifida golma. Right? So this is the culture. Don't forget this culture. I'll share with you the experience of my patient. I treated her with lansoprazole, and then on the next visit I noted that she has put on more than 10 kg of weight within a month. I was a bit apologetic. कि जी next time ये दवाई हम थोड़ी सी ऐसे कर लेंगे कि आपका वजन नहीं बढ़े. But she told me, she was smiling. She has another lady with her. जी ये मेरी देवरानी है. इसके husband ने इसको भेजा कि इसको भी वही दवाई दे दें, so that she can get fat. So culture जो आपके beauty के या दिखाई देने के जो aspects हैं, you can never forget it. ये इसलिए बता रहा हूँ कि anorexia nervosa is very rare in our society. But every third person in a university in UK or US is having some type of eating disorders. So it is actually the perception, not the reality. Can anybody guess? This is a case of anorexia nervosa, where the patient doesn't have a lot of weight, but she is preoccupied with the false belief that her weight is very high. I'll show you a patient. Nobody is allowed to take a photograph. She has consented only to stand here for a few seconds, for a couple of seconds. Right. If you look at her, she is having weight of only 22 kg, and she is avoiding food because she is afraid she will get obese. Take her there. So, anorexia nervosa, where the patient is not actually obese, but I will be using she because a majority of the patients are females, more than 90%. She believes that she is having a lot of weight and she is putting on weight, so they will be using purgatives. They will be, if they eat something, they'll blame herself. Why I am eating? And you will be astonished. This patient was telling us, थोड़ी सी भी अगर खुराक ले लूँ तो उसके बाद मुझे ये बहुत सारी गिल्ट होती है कि मैंने इतनी खुराक क्यों ली. And they will use different purgatives. During this admission, she was telling our trainee that I am having constipation. So although she doesn't know the mechanism, but she is well aware of this thing, how to lose weight. Psychiatric intervention in obesity. Obesity sometimes is the result of a behavior, stress behavior. When people are in stress, they start overeating. The behavior can be modified by CBT. We will be coming to that later. जब मेरे 7 minutes पूरे हो जाए तो एक अलार्म देने ताकि फिर मैं अपना आखिरी मैसेज दे दूँ. Treating the underlying depression, treating the underlying eating disorder, and CBT. A common mistake. Lack of understanding that it is a disease. It cannot be easily, you cannot just easily stop it. हम अपने मरीजों को कभी-कभी we start blaming them for taking more and more food. जिस तरह drug abuse है, people will fall into it and they start drugs, cannabis or any other drug. It is very just simple कि उनको आप बता दें या उनको आप you are at times आपके लहजे में भी गुस्सा होता है कि why don't you stop eating? So this is not so simple that you ask them to stop eating and they will. Second thing is that majority of the obese patients, they don't overeat. Mechanism आपको medicine वाले शायद अभी बता दें. So ये you जो है इस पे काम करना, it is absolutely important but very difficult as well. CBT for obesity. अब इस पिक्चर को देखने के बाद आपको थोड़ा सा ये भी अंदाजा हो जाएगा कि obesity is not always bad looking. It may be very good looking as well. This is our team for CBT, cognitive behavior therapy. इसमें होता क्या है? एक एक्शन, उसके consequences, emotions, फिर behavior. ये आपको अच्छा आसानी से ये कि अगर एक मिनट है ना बात मेरे पास, अगर 3 कैंडिडेट फेल हो जाएं, एक कहे कि जी मैं इसलिए फेल हो गया हूँ कि मैंने पढ़ा नहीं था, आइंदा ज़्यादा पढ़ूंगा. दूसरा कैंडिडेट कहे कि ये जो एडमिनिस्ट्रेशन वाले हैं ये मेरे खिलाफ हैं. तीसरा कैंडिडेट ये कहे कि मैं तो हूँ ही बदकिस्मत. द फर्स्ट कैंडिडेट अगर ये उसके थिंकिंग पैटर्न है तो उसका इमोशन होगा विक्टिम, ये तो मेरे साथ ज्यादती हुई, आई एम डिस्क्रिमिनेटेड, इंतकाम आएगा उसमें. दूसरा जो ये कहेगा कि ये मैंने पढ़ा नहीं है एंड नेक्स्ट टाइम आई विल प्रिपेयर मच बेटर, इस पे काम करना आसान है. So इसी तरह if a patient is having obesity, if you look at the thinking error, if you can identify that, you can, मैं आपको ज़रीन साहब का काम तो ख़राब नहीं करना चाहता, लेकिन you can avoid medications with so much side effects. You can avoid surgery if the behavior can be modified through CBT. ये कॉन्सेप्ट आप लोग खुद कहीं से पढ़ लें. पाकिस्तान में obesity इतनी भी ज़्यादा नहीं है अगर डेफिनेशन को ठीक रखा जाए. अगर आप 25 को भी obesity कहेंगे तो it is very very high, लेकिन अगर आप 39 से ज़्यादा morbid obesity कहेंगे that is not that high. और इसके बाद obesity paradox का एक concept है, we may not discuss it now, लेकिन obesity का सिर्फ नुकसान ही नहीं होता, चंद rarely इसके कुछ फ़वाइद भी हैं. Rarely, I am not promoting it, please don't lose hope. Even if you are in the worst of obesity, even then we can do something. जब आपके पेशेंट का लिम्ब एम्पुटेशन हो जाए उसके बाद भी you start on working how to live with it. So if obesity cannot be reduced, we have the mechanisms where you can understand how to live with it, how to reduce the impact, how to reduce the anxiety and depression, how to reduce the stigma and discrimination. Thank you very much. That's all.
The best project you can work on is you. That's the take-home message from Dr. Imran. Thank you so much, sir. And for all the lighter anecdotes, I hope the students have a lot to learn. I'm sure there's terms being used here that you never heard of before, and there's more to learn. Up next, ladies and gentlemen, we have with us Dr. Sikandar Hayat, Associate Professor of Orthopedics and a renowned name in pediatric orthopedics. He's going to speak to us on obesity and the lower limb biomechanics. Over to you, sir.
So, after the Dr. Imran talk, I think my talk is totally on a different note. And actually why I chose this topic to discuss when Dr. Zareen told me to have a talk on obesity. So I think this is the most practical talk when you have to discuss something in orthopedics. So I will be discussing about the biomechanics of the lower limb in the normally and in obese patients, how this novel biomechanics is affected in obese patients. So as you all know that the major function of the musculoskeletal system is the gait. Okay? So there is the gait cycle. All of you may know that the gait cycle is composed of a stance phase in which our limb is on the ground, and a swing phase when your limb is off the ground. So 60% of your gait is stance phase, while 40% of your gait is of the swing phase. So this normal walking actually is the way for us to move from one point to the other. And if you look at this stance phase mechanism, this is basically a controlled forward fall of the body. When we are standing on a limb, so there is the natural tendency for the body to fall forward. And actually this is the swing limb, when it is moving forward, it controls this forward fall. And this is how we actually move on. So one limb is in the stance and the other is in the swing phase. So the gait starts from the heel strike. So if my right foot is on the heel strike, and when my left foot comes to the ground, so this is basically make one stride. And this one stride is actually composed of stance and swing. So the function of the stance during walking is to accept the weight of the body and have a single limb support, while the function of the swing phase is to have a limb advancement. We have divided these stance and swing phase into different components then for the purpose of discussion and biomechanics. This is actually, I have got two slides more important in my presentation. I have make it very simple. This is the most important one. You can see that this is a stance phase phenomena of the body. The person is standing on the ground while his other limb is off the ground. So during the stance phase, it's not actually the body weight which is passing through the lower limb, rather it is the forces created in the joints by the muscle action also affect the limbs. So during the stance phase, in this way, when we are standing on a platform, so actually we are working against the gravity. So the body has to counteract the gravity, and this gravity is counteracted by a ground reaction force. So normally this ground reaction force passes from the foot to the knee and up to the center of the hip. In the knee joint, this ground reaction force passes anteriorly. So this is very important concept in the biomechanics, that this ground reaction force should pass anterior to the knee joint. As we all know that the knee extensor is the quadricep mechanism. Your quadricep tendon is the knee extensor. But with this ground reaction force, when in the stance phase your limb is extended, this function is not because of the quadricep tendon. It is because of this ground reaction force which is passing anteriorly, it indirectly extends the knee joint. So your quadricep tendon are actually resting in this way. So this is how the nature has provided a mechanism that we should have a gait which is less energy consumption and which is efficient and painless. So when you have got a body weight is more, so what will happen? Your body weight provide a vertical loading to your lower limb. This study, they have compared 15 normal weight people with the 15 obese people, and their gait kinematics and kinetics were evaluated while walking on normal ground. What is kinematics and kinetics? I will discuss shortly. So vertical loading was greater during normal walking in obese people, and this finding was significant with a p-value of 0.007. So vertical loading may increase compressive stress in the knee joint, which may predispose the knee to the osteoarthritis. This is actually the way we are actually assessing the gait, 3D gait analysis. We don't have the facilities for the 3D gait analysis at the moment. We have got a lab in the P-Post, but they provide only 2D gait analysis. Their 3D software is not fully functional as well. So by the 3D gait analysis, actually you assess the kinematics of the lower limb muscles and joints. So what is the kinematics? Kinematics is actually the different joints undergoing movements. So they actually calculate the movement of the joints during the walking. While kinetics is actually the forces created in the joint during walking. So that is also calculated by the 3D gait analysis. So you can calculate whether your joint forces are normal or abnormal. And you can also assess the EMG, and foot pressure actually can be assessed with the normal software. So this sort of the graph we actually have with the 3D gait analysis, and this is the kinematic graph of the knee. You can see this is the swing phase, point of the gait, and this the stance phase, and this is the swing phase. So you can see that the knee is in the flexion when we start the contact, but with the full loading it comes to an extension, and in the swing phase the knee goes to the flexion. So we can assess with this type of graphing. They will provide you the normal graph and the abnormal graph of the patient as well. This is the second most important slide. You can see that when we are standing, half of the body weight is on the one limb and half of the body weight is on the other limb. But when we are walking, so in the stance phase, the body weight is shifted to the limb, while the other limb is completely offloaded. So if a 70 kg man is walking, you may think that the 70 kg body weight is transferred to the limb. No. Because of the muscle forces and the joint reaction forces, it is actually 3 to 5 times of the body weight that is transferred to the limb during the stance phase. So if a patient is suppose 70 kg, so 5 times will be 250 kg weight will be transferred to the lower limb. So you can assess the effect of obesity on the biomechanics when the patient is say 100 kg. Okay? Number one. Number two, you can see there is a red line. This is actually the mechanical axis of the lower limb. It passes from the hip to the ankle, center of the hip to the center of the ankle, and normally it should pass through the center of the knee joint. Okay, so when the patient has got an arthritis, okay, so he will have a deformity at the knee joint which is called varus deformity. So this mechanical axis will be shifted medially. So during walking, the whole stress will be passed to the medial joint line. So this is just a study to have an effect of the weight loss on the knee loading, and you can assess the last one, that when you lose 1 kg of weight, actually the benefit to the knee will be more than 2.2 kg. And this is some biomechanics how the obesity causes osteoarthritis in the knee joint. So obesity will have an increased axial forces to the knee that will predispose to the osteoarthritis of the knee and to some extent to the hip as well. But there are some local factors as well. And this slide explains those local factors. That when you have got a deformity, of the varus, so it will increase the pressure on the medial side. So there will be increased medial loading, more tibiofemoral arthritis, and a vicious circle will be formed, which will increase the arthritis on the knee joint. So this is another study which assesses the joint space width on the deformity. So this is a neutral, this is valgus, and this is varus. So you can see when you have got a varus deformity, which is in the osteoarthritis of the hip, the joint space width is decreased. A lot of joint space is lost with the obesity and varus male alignments. Okay, thank you so much. I think we can finish. Any questions?
Thank you so much, Dr. Sikandar. We have 2 more lined up. After that, we move towards the student quiz. They say a surgeon is afraid of 2 things, God and hemorrhage. If I said anesthesia is a close third, I won't be wrong. They are the closest to us in the theater. If a surgeon is struggling with an obese patient, it is not easy for the anesthetist as well. Let's hear it from Professor Javed, Dr. Javed from Anesthesia Department, who's going to speak to us on the anesthetist challenges in bariatric surgery. A round of applause for Dr. Javed. Once more for the audience, if you have your questions, keep them safe. We're about to give you the question answers in the end.
Assalamu alaikum. My name is Dr. Mohammad Javed Khan, Assistant Professor at the Anesthesia Department. For those of you who don't know us, this is our anesthesia faculty. Now I would like to present case of bariatric anesthesia. Now, what are the anesthetic challenges we face in OR while anesthetizing these obese patients? You can see on the right side that this old lady has got a short neck, so there must be some difficulty while intubating the patient. Now, if you go peripherally, there will be fat deposition, so there is also a chance of difficult IV cannulation. Now, if we see the chest, there is a fat deposition as well on the chest, so there will be decreased lung compliance. So the FRC will be reduced. We will cope these challenges while anesthetizing these patients. Now, if we go towards abdomen, the gastroesophageal reflux and the gastroesophageal sphincter is loose, so and incompetent. So the gastric reflux is very common in these obese patients. Now, if we go distally and towards the lower limb, we will see that there are chances of deep vein thrombosis. Now, picture on the left side shows some challenges while placing epidural anesthesia or analgesia. These incisions made on abdomen also require analgesic post-operatively. So we place an epidural and we give opioids and with local anesthetics to provide post-operative analgesia. You can see that this anesthetist is trying to palpate the spinous process. He has got some difficulty because of the fat deposition. What he can do to solve this problem, he can use ultrasound or he can use a C-arm or a fluoroscope to locate the spinous process. There he will put a mark, then he will do the epidural. That would make his life easy. Now, this was the whole summary of my presentation on these two pictures. But now we will go one by one. What are the airway and how the airway is managed? Now, anatomy, physiology, pathophysiology, as discussed by Dr. Hamza, all of these are disturbed in morbid obese patients. What are the changes in anatomy? You can see the airway is distorted because of this deposition of fat everywhere and around the neck and around the mandible. Regional blocks, I told you. Then nutritional nerve injury, you need to provide padding for the peripheral nerves to protect these nerves. What airway problems are anticipated? Now you can see these diagrams. These short neck, these large tongue. Now, how can we decide that this patient would present difficult intubation? Mostly, this is a very significant point. Short and thick neck. If it's more than, if you measure it with measuring tape and it's more than 40 centimeters, it will definitely go towards the difficult intubation side. Limited neck movement, yes, of course, that's also a possibility to fat. Large tongue. Then the other thing which is very important is the thick neck and the Modification classification, which will be coming soon. You will see. While examining this patient in pre-op clinic, you should take history of the stop questionnaire. Snoring, Dr. Rosanna will discuss about the obstructive sleep apnea, tiredness or daytime somnolence, any observed apnea, any blood pressure, hypertension, comorbidities and cardiopulmonary reserves. Now this is very important. Comorbids, if the patient is having obstructive sleep apnea or if he is having right or left heart failure, obesity. Please remember, obesity affects both sides of the heart. not only the right heart, because there is a restrictive lung pattern, it affects the right heart and right heart hypertrophy, but it also it causes hypertension, which also affects the left heart as well. So comorbid patients are definitely candidate for HDU and ICU bed arrangement should be done prior to anesthetizing these patients. The pulmonary issues, obstructive apnea, definitely they are oxygen dependent, so we will need a consent for post-operative ventilation. Past anesthetic history, these patients who have been anesthetized with some difficulty, they usually carry a card. There it has been mentioned that they were intubated with a bougie or with support of a video laryngoscope or with a fiber optic. So you can get a clue while anesthetizing these patients for a second time. This is a mnemonic lemon just to look for obesity, and this myopathy is very important. See this myopathy, this is for all students. You make the patient sit in front of you and you ask the patient to protrude her tongue. If you cannot see the uvula, this third and fourth is definitely a difficult intubation. Myopathy 3 and 4. The mnemonic for it is push. Fascial pillars, uvula, soft and hard palate. If it's all seen, it's easy intubation. If it's the uvula is not seen or partially seen, these two are difficult intubation. This is kind of a repetition. Comorbid discussed. Post-preoperative, yes, these DVT prophylaxis in form of pharmacotherapy or exercises or pneumonic stockings. Vein, this is infrared vein locator. We do have this in OT. Monitoring ECG, end-tidal, and SpO2. These are the monitors. Now one would ask why not invasive monitors? Invasive monitors are only applied for those patients who have difficult IV access or who have comorbids. For comorbids, we will place intra-arterial line, not every patient. The induction and intubation, please remember, as I told you in the initial presentation, initial figure, that these are considered full stomach, so you have to give propofol or pentothal and then a short acting muscle relaxant like succinylcholine and intubate it immediately. That's called rapid sequence induction. Now in difficult intubation cases, you have to have this difficult intubation trolley. These have all the tools, the video laryngoscope, the different masks, the laryngoscopes, the cricothyrotomy set, the reverse tender bulb position. This is very important for patients who are morbid obese. This will and put some towels behind his or her shoulder. This will somewhat extend the neck. Reverse tender bulb position is that when the head end is up and the lower limb is down. This is called reverse tender bulb position, and it facilitates intubation. So this is fiber optic awake. This difficult intubation, so fiber optic awake intubation is being performed. Post-operatively, oxygen therapy should continue, and 30 to 40 degrees the patient should remain headed up. It will increase the FRC. Apart from the usual care in ICU, you will need DVT prophylaxis, post-operative nausea vomiting prophylaxis, and rest of the things are routine. Now this is a CPAP mask. You can see that those patients who are dependent on CPAP mask, they will definitely need CPAP mask in post-operative period. And unless the anesthetist is not sure, he will not extubate or remove these CPAP masks. This will be monitored through SpO2 and pulse ox. And the patient would keep up, will be kept 30 degree head up position. These are the pneumatic compression stocking for DVT prophylaxis. Thank you.
Thank you, Dr. Javed. The male side students, please maintain decorum. We're about to move on towards our last presentation. As part of our routine pre-op screening for bariatric patients who undergo surgery, we routinely consult our pulmonology department to throw light on a very important aspect, which is the obstructive sleep apnea. May I please have on stage the Associate Professor of Pulmonology, Dr. Rosana Javed Farooqi. A round of applause for Madam, please. She's been diligent throughout. Students are requested to maintain their decorum, please.
I'm Dr. Rosana Javed Farooqi. I'm Associate Professor of Pulmonology. Okay. Actually, the time is very less, but I try to पूजे में बंद करने की कोशिश करूँगी दरिया और समंदर दोनों. So the topic which was given to me is the obstructive sleep apnea and obesity. Actually, obstructive sleep apnea is associated with obesity. So how will we define morbidly obese patients which come to us, they are mostly come with obstructive sleep apnea. They are so much morbidly obese that they can't be moved in and out. They are oxygen dependent and they are in very bad shape, in type 2 failures. So how we define obstructive sleep apnea? It is obstructive sleep apnea is a disorder characterized by repetitive collapse of the upper airway during sleep, resulting in changes in the ventilation with intermittent hypoxemia and arousals, resulting in diurnal sleepiness which leads to cognitive impairment and cardiovascular morbidity. So we diagnosed OSA by apnea-hypopnea index, which is calculated by the sleep study which do it in our ward. What is apnea? It is the cessation of airflow for at least 10 seconds, and hypopnea is the transient reduction not complete for 10 seconds or longer. So apnea-hypopnea index is the total number of apnea and hypopnea divided by the total sleep time. So normal is less than 5, while mild is 5 to 15 and more than 30 is sphere form. So there are 3 types. The obstructive type, in which there is collapse of the upper airway leading to apneas, while the central one, there is brain signals are fail to give respiratory muscle to do respiration, and the mixed type is the mix of the 2. So why OSA and BMI? There is a great association between OSA and BMI. So there is 10% increase in the weight and leading to 6-fold increase in the risk of OSA. 21% who are overweight having OSA, while 63% who have got BMI of more than 30, they will have OSA. So the top 10 country which got this OSA, and the top one is the China, but Pakistan is also included in it. So what is the pathophysiology? During sleep, the postural muscles get relaxed, and including pharyngeal wall muscles, so they suck in and they cause apnea and hypopnea. So there is internal obstruction, that is because of the enlarged tonsil, adenites or facial deformities, and external compression is because of obesity, especially the neck obesity and the central obesity. So complication of the OSA are related to obesity. They have a memory loss, they have impotence, lung hypertension, stroke, headache, hypertension, drowsiness, arrhythmia, and diabetes. So how will you diagnose? as we do in our wards, we take the history. The history comprises of 3 main symptoms. That is snoring, daytime sleepiness, and nighttime symptoms. Then we do the clinical evaluation on 2 scores, that is ESS score, that is Epworth sleepiness score, and stop bang. And then we do the investigation, that is sleep study. So there are mainly 2 symptoms. The nighttime symptoms, that is loud snoring, witness apnea, gasping for air, restless sleep, and frequent going to the washroom. That lead to daytime symptoms. There is early morning headaches, daytime sleepiness, poor concentration, irritability, and sleep at work. This is very important. So the excessive daytime sleepiness can be assessed by ESS score. It is a questionnaire which helps to determine how frequently the patient will doze in 8 frequent questions important. That is sitting and reading, watching TV, sitting inactive in a space, and if it is more than 11 to 15, that is have got a moderate risk of having OSA, and above 16 have got severe. NES has also been done to see the treatment response. So clinical examination, the obesity is the most common. The BMI is more than 30 kg per meter square, having large neck circumference, that is between 15 to 17 inches, in large tonsils, retrogantria, microgantria, and high arch palate. So for diagnosis and confirming that patient has got OSA, we need a sleep lab. So American Academy of Sleep Medicine have given 4 levels of sleep labs. Level 1 having got in-lab polysomnography, which need to be attended by a sleep technician, and the level 4 is monochannel, it is unattended, it can be done at home. But the inpatient sleep study is the gold standard for diagnosing OSA. So level 1 polysomnogram, it is a specialized way to monitor body physiological responses, and alhamdulillah we have here in pulmonology unit the level 1. So it can measure all the things like EEG, ECG, EMG, electropologram, nasal and oral airflow, pulse oximetry, snoring and sound recording, and leg movement. We recently have this installed in our unit. You can see we are standing, to have the readings, and this is the recording room. It is in the other room. You can see the camera, the technician will see all the things which will happen inside the sleep room. This type of recording will come. You can see that there is no airflow here. The respiratory effort is there. So this is obstructive sleep apnea. So you can diagnose both obstructive as well as central sleep apnea. So we have done research work, alhamdulillah. 1 paper was published by me in 2012. Second is going to be published soon. It is frequency of obstructive sleep apnea in a COPD patient. And the third is going on, that is OSA in ischemic heart disease patient. So the treatment management. So as in every case, you have a conservative management and you have a surgical management. So in conservative management, you have to, number 1 is that same, the lifetime style change. But morbidly, in these patients, they don't change their style. And other is the CPAP therapy, and then is the pharmacological therapy, and then surgical, which is already discussed by the surgical department. So mild disease, you can have a weight reduction, like 10% weight loss can improve 26 reduction in respiratory disturbance index, avoid alcohol, sleep in later position, and then the CPAP therapy. CPAP therapy is the treatment of choice because it increase the caliber of airway, retroparietal and retroglossal regions, maintain the UA patency during sleep, and soft tissue during from collapsing. Indication of CPAP, all the patients who have AHI more than 15 are the need CPAP, while patients who have AHI between less than 15 and having got symptoms of hypersomnolence and hypertension and cardiovascular, they need CPAP. The drug therapy which is being used and the FDA approved is a modafinil. It is given when CPAP is not properly working. moreover, the serotonin uptake inhibitors can also be used. They have to increase genoglossal activity and REM sleep. This is other modalities if failed by CPAP, that is biotherapy, when there is obstructive sleep apnea and overlap with COPD, you need BiPAP therapy. Oral appliances, if there is problem with the teeth, you have appliances for the mouth, surgical correction of the upper airway, and upper airway stimulation therapy, which is new now in the treatment. Surgical treatment could be nasal surgery, tonsillectomy, laser-assisted neoplasty, maxillomandibular advancement strategy, and tracheostomy. And then the bariatric surgery, I don't need to discuss it because it already discussed. I just want to give you a take-home message. If you got snoring, only consult your ENT people. If you got snoring with obesity and apneas, consult us, pulmonologists. If you have got all these things, consult the surgeons for bariatric surgery. Thank you very much.
Thank you, Dr. Usana. That's a very precise take-home message. With this, the presentations come to a close. I'm now going to invite on stage Professor Dr. Zareen. You're the General Secretary of Pakistan Society for Metabolic and Bariatric Surgery. The Dean visioned this CPC to come to Khyber Medical College, our alma mater, and Dr. Zareen has practically executed this. Let's have Dr. Zareen on stage. He'll briefly speak to you about bariatric surgery and more.
I'm extremely thankful to all speakers who spared their valuable time and came here. It's all because of the academic vision of our Dean KMC that we all are here to speak on this important subject. Although there is a lot more to speak on the subject from different other specialties like dermatology, plastic surgery, nephrology, cardiology, and more importantly, gynecology. Because in my personal experience, the patients whom I operated on for infertility, we got almost 100% results. A few months back, I got a patient who was here for weight loss surgery. I counseled her, put her on pre-op diet plan, and asked her to come after a few weeks' time for this. But she totally refused to follow the pathway. And the plea was that I want to reduce my weight within the coming week or two. Otherwise, my husband will get another wife. So I just asked her to try something else. Bariatric surgery is not going to help you. Every time there is new development, although Dr. Asad has talked a lot about the bariatric surgery and its metabolic and bariatric effects, the medicine colleagues and endocrinologists will agree with me. Every time they will get patients with low BMI and comorbids, and which are totally resilient and resistant to the medical therapy. So there is some more to develop on that subject also. There is another procedure, surgical procedure for low BMI patients, and currently only for type 2 diabetes. So patients having low BMI like 25, 26, 27, if you perform a bariatric procedure, they are going to lose a lot of weight, which can have a lot of nutritional complications. So there is another procedure by the name of SASI and S-SASI, in which we construct a sleeve, but this time the sleeve is quite huge and big, with a lot of capacity of more than 200 cc. And the stapling procedure is started 7-8 centimeters proximal to the pyloric end of the stomach, and the major portion of the fundus is removed, right, while the rest of the stomach is left alone. And then the pre-pyloric region of the stomach is anastomosed to the jejunum 150 and 200 centimeters away from the DJ junction. So although it will not lead to a lot of weight loss, but the metabolic effect is quite promising, and there are a lot of studies going on this subject. And it's because of these neuroendocrine modulation which can lead to type 2 diabetic control. And is these stapling devices, they are quite costly, and most of the patients, they have got these constraints. So there is another procedure by the name of S-SASI, that is known as staple-less SASI, sleeve, single anastomosis sleeve aerial bypass, in which the same sleeve is achieved by only plication of the stomach, and then the prepyloric end of the stomach is anastomosed to the jejunum. So it will help in the control of diabetes only. Although it can lead to a little bit weight of loss, but not to the extent that it can cause malnutrition. A lot of work is currently going on in this in the Middle East, Singapore, and some countries of the Europe. So hopefully soon it will be launched here, and we will be working on that. Thank you very much.
Thank you so much, Dr. Sri. With this, we come to the end of the CPC on the theme of obesity. I'd now like to invite the man behind the vision, our Dean, Professor Dr. Mahmood Aurangzeb, who has been so kind from the day I first went to record his video clip. He's been very guiding. Thanks to Dr. Iqbal, Dr. Hamza, everyone has been guiding us along the way. A round of applause for our Dean, sir. Please, once more.
Bismillahirrahmanirrahim. Samra, thank you so much. It's an absolute joy today to see final year students sitting amongst postgraduate trainee doctors and your distinguished senior faculty. I want to ask you all, did you enjoy it? Yes. Now, the vision behind was to first of all start a monthly academic activity which was suspended because of the COVID pandemic. And I was given a reminder by our chairperson of our board, and obviously safety was of paramount importance. So when things started easing off, I thought it's best that we move the venue from Khyber Teaching Hospital to the medical college. That will give us, if it's once a month, there's nothing difficult about it. You get a chance to see all your senior faculty. They're all very distinguished people in their respective fields. Interact with you, and you get a flavor of what life is going to be in the next year or two once you get into clinical practice. There was too much, there was a gulf between the medical college and the hospital. So you went there for your clinical rounds, but you didn't know much about the academic activity that goes on. Now, this whole thing has been made a success for me. Yes, the leader comes with a certain vision, but it's very important for the leader to have a very good team. And the one thing that I excel in, and I've always been credited with, is that I always like to work in a team rather than work in isolation. That I don't do at all. I will take everybody along in whatever I plan to do. So this has been made a success story for me by Dr. Iqbal Haider. Please, a round of applause. Then I give the credit to Dr. Alina Badshah, who we obviously, we surgeons are mechanics and not as sophisticated and glamorous and ostentatious and as intellectual as physicians. So it was not going to be possible to rob their right. So we started off with the physicians in the seminal inaugural session, which was, and they set the stage very high for us. But I would like to congratulate Professor Mahmoonir. She's my boss, by the way, all right? Now the Department of Surgery, it's a man's world. But if you want to come to surgery, it's not a man's world, it's a woman's world, because she's the boss. And she set a fantastic stage, and Samra has worked very hard. Dr. Zerine. Now, what was all this about? Number one, it's a burning issue. It's a hot topic. And I would urge Professor Mushtaq and Mahmoonir to please incorporate some questions in their upcoming exam on obesity. The subject is of paramount importance. Then what did you learn from this? What you learn from this, in the end, of course, the star performer or the prima donna of this whole thing is Professor Zalim, because he will be the one physically operating on it. But he cannot work in isolation. Out of the question. Did you see the checklist of the patient, the workup for an obese patient? Yes. About half an hour back. You cannot cut corners. You cannot circumvent around it. Unless you meet all the requirements, your surgery is going to end up in disaster. And I'll tell you why. So it's a multidisciplinary approach. There is nothing in medicine today which is the exclusive domain of Mahmoud Aurangzeb or Professor Jamila or Professor Ishaq Khattak. He's constantly consulting with me, I'm constantly consulting, and this is the safe and the modern way ahead. Multidisciplinary. In fact, now we are hearing about words like transdisciplinary and now interdisciplinary, in which you involve the community also. So you got a flavor. The topic was obesity, and we got a general introduction with a case history. That is how they all start. Dr. Imran very eloquently gave you the psychiatric aspects of it. Now that is a fact, because when I get obese patients to operate on, it's very difficult for the surgeons. To begin with, the depths in which the organs lie make it technically difficult. The other thing is the grease pouring out of the fat. We can't even hold our instruments properly. And the poor person retracting the wound for us. So it's a challenge from the beginning to the end. Then the respiratory aspects covered so eloquently by Dr. Roxana. Thank you very much. Sleep apnea is a very serious issue. And I know of a lot of friends and relatives that are actually on CPAP treatment for it. And then, Dr. Hamza very nicely, he's a very good speaker by the way, presented the medical aspects of it. And he highlighted the role of medicine in it. And have I missed out anyone? Yes, and Dr. Javed about the anesthetic aspects of it. And I've been in that situation, and my colleagues have been, where we all scrub, the patient's all ready, and they can't get a bloody tube inside. Now, it's not their fault. It's the fault, it's the challenge that the patient poses. So you can see so many disciplines were involved in treating an obese patient. Coming now to another aspect of this grand round. You can judge for yourselves that who had nice speaking abilities. You're never born a good orator, by the way. It comes through practice, it comes through recordings, it comes through feedback. So we'd like a feedback on every aspect of it. There are some people that are not good orators. So this is a means of improving your communication skills, which is now such an essential part of medical education. I'll finally come to how we sort of start off a particular subject. Now when I get these obese patients, particularly females, that I need to operate, and I said, "Bibi, what do you So I said, no, you're not doing that. Then you take the cream, the pera, the malai, my shirting they reserve the best for themselves. They're bingers. Nobody is watching them. I'm not blaming the female gender for this, but these people, they are closet eaters. They will never confess to the fact that they have an eating disorder. So that is one thing. The other thing is, let's talk about laparoscopic surgery. I'll just take another minute. There was no laparoscopic surgery being done when I was in training here. Then a period came, the governments of the time have the right to bring about reforms. It's their prerogative whether we like it or not. You don't like it, leave it. Otherwise, you've got to conform to them. So in 2002, if you all remember, again, the guillotine fell on us that you can't do private practice. Now, why do we do private practice? It is our right. I can't possibly sustain myself with the salary that I'm getting. So I supplemented by doing private work outside of my working duty hours. And that was taken away from us. So despondently, I went back to England and I re-registered there. And I said, all right, I'll buy time. But I had a very supportive doctor that I worked with, a Scotsman. And this was in an area, if you're familiar with, it's called Kent, outside of London. So I said, you know, this is what's happened to us in our hometowns. He said, why don't you try something new? Is anybody doing laparoscopic surgery? So I said, no one is. So he said, start off. And you know that when you see a laparoscopy tower, it has a monitor, it has an insufflator, it has a camera head, and then it has a diathermy. So I assembled it, and lo and behold, each one was from a different company. But I invested in that. And I started off in secrecy, because I didn't know the direction I'd be going in. When I completed my first 100 cases of laparoscopic cholecystectomy, you know, I had a big party. And the news spread like wildfire that this is doable, it's safe, it's easier than an open operation. And today, laparoscopic surgery is being conducted in practically every district. And I do take the credit to myself that I broke the shackles and the myth that this is something unachievable. Should Mahmoud Aurangzeb have the exclusive title and, you know, the rights of taking it further? No, I didn't. I stuck to where I was, and, you know, a new generation of people came up, and exemplified by this entire surgical department. And first and foremost is Dr. Zareen. He was audacious. Now, Mushtaq and I decided that should I step onto bariatric surgery, and I took 2 weeks off and I went off to a hospital in Birmingham, outside Birmingham, Walsall, to a Pakistani surgeon, by the way, Amir Khan, who had so much experience in bariatric surgery that he was among the pioneers of bariatric. I'm not talking about laparoscopic bariatric surgery. He was among the pioneers of open bariatric surgery. So in the 70s, he had started it off. And I spent the time with him. Now, obviously, being a surgeon, my comfort zone is being in the operating theater. But I wasn't getting there. So he made me spend a day with a nutritionist. Then the next day was spent with a psychiatrist. Then all obesity-related. The third day with a psychologist. You have to determine that, is this patient determined to go through this surgery? And I'll tell you what, you saw these fantastic illustrations, the gastric bypass, you know, the duodenal switch and the Roux-en-Y bypass. Do you know what? If you're not compliant with all these restrictive and malabsorptive procedures, you will attain your pre-operative weight within 18 months. Do you get my point? So it's not that, you know, stapling, mapling, and I go and eat golgappas and I have gulab jamuns and things. It's gone forever. You become non-compliant and the entire thing will fail. So you heard firsthand about the philosophy of bariatric surgery, what it's about, what are the different aspects of it, and then from the personal experience that people have had. Zareen, at one point I felt there are some costs associated with it. If you're going to do it laparoscopically, and by the way, let me tell you just one other thing. When you're doing bariatric surgery, you need to retract the liver, because mention was made of a crucial point called the angle of Heese. Now, if you do any damage in that area, it's going to end up in disaster and death of a patient. You need to retract the liver. There's a retractor which was designed by an Australian surgeon by the name of Nathanson. It's a very handy retractor. But the livers of these obese patients are so heavy,
And when you look at them laparoscopically, you know, they're mottled brown and yellowish, and you can see that this patient's liver is just about to explode. You apply that Nathanson retractor to lift the liver up. Do you know the retractor actually starts fracturing the liver? That's how serious the problem is. So we put them on a 2-week liver reduction diet. We beg and plead that please, these 2 weeks are crucial so that at least that retractor can function. So it is challenging right across. Now, why is there so much responsibility ultimately on the shoulders of the surgeon? Because inherently the condition, although associated with hypertension, diabetes, osteoarthritis, Dr. Sikandar, of course, I forgot him, very nice mechanism of how it all shifts. But if things go wrong, these patients are very, very unforgiving. The reason for that is that there are certain costs associated with it. The average cost of a bariatric procedure, say Dr. Zaleen does not charge a single penny. The disposables are such that I think it's about $1.5 to $2 lakh. There we are. So there are a lot of costs associated with it. So a word of caution from my side and to Dr. Zaleen. You may do 1,000 cases successfully. It will be the 1,001st that will throw you into a pit. And by the time you get out of it or crawl out of it, you know, it takes its toll on you. So the way to go ahead is to be extremely cautious. Please give an average of about 6 months to your patients to learn about the philosophy of bariatric surgery, to earn the procedure, and to beg and plead and to prove to you and the psychologist and the diabetologist that I really deserve this and I'm begging for it and I'm prepared for all the consequences. Thank you all very much. I think we started off with the heavyweight departments, and I think next in line, Professor Jamila is gynecology. Choose a topic which covers all the disciplines. I thank you for your patience. Why? You were not there at the time, and I thought we'd involve 4th year and final year. But that was a disaster. They disturbed us so much, no respect for the speakers, so I have restricted it to final year only. You pass, and you make me proud. Thank you.
Thank you very much, Dr. Mahmood. What a delight listening to his anecdotes from all his patient experiences. I hope the students realize you're in the company of some very fine, accomplished people here. And you should be very grateful to your team for starting this for you. So 10 seconds of clapping for that. Okay, now something I've been announcing throughout because I wanted you guys to sit tight in your seats. This is a student quiz. I'm going to announce the teams. Dr. Khan, are you with us? Team B is right behind you. Team A, kaun si hai? That is Team A. This is Team B. Do you have your buzzers? Okay, I'm going to call your names. You're going to stand up quickly so the crowd knows who you are. Team A, Abdul Majid, raise your hand. Hafsa Sadr, Sabir Shah, Hazur Ahmed, Saifullah and Samra Rahim. This is Team A on the right side. Team B, we have Sabahat Safdar, Muhammad Yunus, John Sheikh, Muhammad Talha, Muhammad Anas and Loeza. Alright, now the question is going to display on the screen and you're going, if you know the answer, you're going to give us a buzzer. Dr. Khan will start writing your scores. We have 10 questions in total. If this goes to a tie, I have 3 tiebreaker questions. If it doesn't, I'm going to float the questions for the audience and see if they know the answers. silence. Trainees who are leaving, please leave in silence if you have to. Okay, Dr. Khan. Now the first question to both the teams is, what does BMI stand for? Team B. The answer came is body mass index. That's correct. That's 1 point to Team B. The next question is, crowd आप सिर्फ clap कर सकते हैं, शोर नहीं करेंगे, ठीक है? Well, let me say the question first. You receive a patient in the OPD, his BMI turns out to be 28. What would you label this patient? No, you can't just shout the answer. You have to give me the buzzer. Okay, it's Team B. Overweight. Correct answer, Team B 2, Team A 0. Okay. If you don't follow the rules, you're going to lose it. Don't shout the answer, just give me a buzzer, okay? Now, which of these is an ideal diet for weight maintenance? Team A. Okay, the answer from Team A is high protein, low carbs. Let's see. That's correct. Listen to the question first. Leptin is a hormone produced by which of the following? Adipose tissue, pancreas, spleen, or the liver? Team A. The answer they gave is adipose tissue. That's correct. Which of the following hormones does not induce satiety, that is the sense of fullness? Team B. Say it in the mic. Okay, the answer from Team A is A, renin. That's correct. Team B not only lost their answer, but it was a wrong answer. Now, listen to the question. One of the following is not a bariatric procedure. Which one? Team A. Option D, Partington Rochelle. That's correct. Just excluded this, you have no idea. Which of the following is needed for strong immunity and connective tissue strength? No, it's Team B, yes?
Vitamin C.
That's correct. What are the scores for now? Now, if you eat fewer calories than you burn, what kind of a diet are you on? A keto diet, a crash protein diet, a calorie deficit diet, or intermittent fasting? Team A. What is it? Excellent, it's a calorie deficit diet. Which of the following burns the most calories per hour? Team B. That's the wrong answer. Team A, if you get this right, you get the score. Rope jumping. Rope jumping, that's right. Okay, the crowd, please maintain silence. Is this a tie?
No, man.
That's Team A, right? I hope I don't announce the wrong winner. Excessive overeating that feels out of control is a feature of which disorder? Team B. That's the wrong answer. It's a binge eating disorder. I think we have a clear winner. Team A. Okay, you're going to receive a prize to redeem here, but I'm just going to do this for the crowd, okay? So just raise your hand if you know the answer. The consultants can answer too. Who performed the first bariatric surgery? It's not Dr. Zareem. A.J. Kremen, that's right. Okay, one of these famous chefs underwent bariatric surgery. Can you name who? Gordon Ramsay, Nigella Lawson, or Brad Elliott? Wrong, it's not Gordon Ramsay. He's famous for something else. Team sir, do you know the answer? No, sir. Dr. Zuri, do you know the answer? Brad Elliott, that's right. Okay, it's this guy. And last, this was on one of the presentations. Anyone who knows what does PS and BS stand for? No, don't say A or B or C. Raise your hand and I'll ask you. Yes. That's right, Pakistan Society of Metabolic and Bariatric Surgeons. Okay, so I'm going to invite the Dean and the Associate Dean to please give away the winner prize to the winning team. Come down, Team A. Let them go just like that. Team B, come down and receive your bouquet from the Dean. Team B, Sarah, Yunus, John Shea, Talha, Anas, and Louisa, thank you for participating. Thank you everyone for coming to our CPC. Hand over the Dr. Khazana. The runner bouquet, please. The runner-up team. I request all our consultants to please stay for the group photo with the dean outside. Thank you students. Thank you our dean, Zareen sir and everyone. Thank you very much everybody.